Cardiorespiratory fitness, or CRF as I'll refer to it in this report, is an important yet vastly underutilized and undervalued clinical marker of both health and disease status. Hi, I'm Dr. Lenny Kaminsky. I direct the Fisher Institute of Health and Well-Being here at Ball State University and was the senior author on this paper published in the Mayo Clinic Proceedings. The title of our paper was The Development of Global Standards from Directly Measured Cardiorespiratory Fitness Values, a report from the Fitness Registry and Importance of Exercise National Database, which we abbreviate as FRIEND. I want to thank and acknowledge the co-authors on this paper. We were led by Dr. Jim Peterman here at Ball State University. We also had co-founders of the FRIEND Registry, Dr. Ross Arena and Dr. John Myers, participate, along with Dr. Levy, and contributors from Canada, Dr. Marzolini and Dr. Ross, and contributors from Norway, which included Dr. Stensvold and Dr. Wisloff. The research evidence is clear and conclusive. Those with low cardiorespiratory fitness have increased risk of many diseases. These include cardiovascular disease, diabetes, dementia, and multiple types of cancer. Whereas those with higher levels of CRF receive protection from premature mortality from all these different diseases. Indeed, it is well established if we compare major risk factors. So if we look at CRF compared to the three major risk factors, cigarette smoking, hypertension, hypercholesterolemia, and even to diabetes, CRF is a strong or stronger predictor than those other major risk factors. This body of evidence was recently summarized in an important scientific statement published by the American Heart Association. In the conclusion from that report, it was recommended that CRF should be routinely measured in clinical practice, i.e., CRF should be considered a clinical vital sign. One primary limitation to the use of CRF in the clinical setting has been questions about how do we interpret CRF values. Most studies that have been conducted use their own cohort-specific values to determine CRF thresholds of what could be important relative to health and disease status. For example, one often cited CRF risk threshold is 6 METs, which is the equivalent of 21 milliliters of oxygen per kilogram of body weight per minute in terms of oxygen consumption. Values below this were noted to cause increased risk for people relative to premature mortality as well as some of the disease states. However, the use of an absolute CRF threshold, such as 6 METs, could be problematic. For example, we know that these values can vary quite markedly between different age groups as well as between both sexes. To address this issue, we developed the Fitness Registry and Importance of Exercise National Database, or FRIEND. And in 2015, in the Mayo Clinic Proceedings, we published the first US-based reference standards for CRF values using treadmill as the mode of exercise. This was followed in 2017 by an equivalent report using cycle as the mode of exercise. In these reports, we compared our US-based reference standards to two smaller cohorts that had been published from Norway. In these comparisons, we noted that the values in Norway were markedly higher than the values in the United States. This was also demonstrated recently in another study that was published by our co-author, Dr. Wisloff. In their report, they used an estimate of cardiorespiratory fitness that was derived from a web-based questionnaire. And in that report, they showed variation between countries across the globe. Presently, there is no international database for measured cardiorespiratory fitness values. This was a logical extension for the FRIEND Registry to include international data in our database. So with this report, we began developing the first global reference standards for directly measured cardiorespiratory fitness. In our paper, we have data from 3 different countries, Canada, Norway, and the United States. All were from individuals between the ages of 20 to 79 years of age. All were considered apparently healthy, and we had 11,676 tests, 45% of whom were conducted on women. One of the findings of the report was, on average, values for men were 26% higher than values for women. Also, if we looked across age groups, there was a 10% decline in VO2 max, or CRF values, across the decades. These differences in age and sex-specific CRF reference values are important for us to individualize risk estimates for patients as well as subjects in our research studies. One example of this can be noted from something we reported in the paper. If we use that 6 MET value for a 65-year-old man, he would be placed in the 10th percentile. If we use that same 6 MET value for a 65-year-old woman, she would be placed in the 30th percentile. However, for a 25-year-old man with a 6 MET value, he would only be in the 1st percentile. Our findings clearly demonstrate heterogeneity between countries in directly measured CRF values, both in the report we had here with data from Canada, Norway, and the United States, as well as other recent reports in the literature from other countries. These findings set the stage for how CRF values that vary between countries may relate to differences in health status between countries for a variety of different chronic diseases. For now, these initial global reference standards with directly measured cardiorespiratory fitness values will be of help for both clinicians as well as researchers in interpreting their CRF values and using those values to indicate health status for the individuals. Our next step is to continue building the FRIEND-I registry. We welcome investigators from around the globe to contribute directly measured cardiorespiratory fitness values to the FRIEND registry. Thank you for listening to this information about our recent publication in the Mayo Clinic Proceedings.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.